Hello, my name's Chris Patterson. I'm one of the stroke consultants here in Bradford and the clinical lead for stroke services. I'd just like to explain briefly what a stroke is and why it's important. A stroke is what happens when there's an interruption of blood supply to part of the brain, and the effects of a stroke depend very much on which part of the brain's affected, how much of the brain, and what type of stroke it is. There are two types of stroke. The least common is a bleeding type of stroke or a hemorrhage, and that accounts for about 10 to 15% of all strokes. The commonest type of stroke is called an ischemic stroke, and it's due to a blockage of one of the arteries in the brain. Patients who have ischemic strokes may be suitable for an emergency type of treatment called thrombolysis, which involves an injection, and it can help up to about 30% of people, provided they arrive in hospital in good time. There is a time window of 4.5 hours for this treatment to be effective. In an ideal situation, the pathway for patients who have a stroke should be as follows. The patient now very commonly recognises the symptoms of stroke due to the very successful FAST campaign, the face-arm speech test that you may have seen on television. In the ideal situation, the patient calls a 999 ambulance and the paramedics are trained to recognise the signs and symptoms of a stroke. If patients are FAST positive, they should be sent by emergency ambulance to the casualty department, and a pre-alert telephone call will be made to the hospital to warn the stroke team that a patient will be coming with a suspected stroke. On arrival to casualty, the patient will be met by the stroke team and the A&E staff, and they will be triaged and assessed very quickly to decide whether indeed this has been a stroke or not. The patient will receive an urgent CT scan if appropriate, and if the patient is felt to be suitable for thrombolysis treatment. This will all happen within an hour or so of arrival. Once patients have been assessed and treated in the casualty department, they're then moved immediately to a hyperacute stroke unit bed or HASU bed. This is like an intensive care ward for stroke patients, and it's anticipated that all suspected stroke patients will be admitted to one of these beds for the first 24 to 72 hours of their stay. Once the patient's been stabilised and they're safe to move off the HASU bed, they're moved normally to one of the acute stroke unit beds. If the patient recovers very quickly, they may be discharged home. And once they're stable and require rehabilitation, patients can then move to a rehabilitation stroke unit. The outcomes following a stroke depend very much on whereabouts you're looked after in the hospital. We've known for over 20 years that if you spend time on a dedicated stroke unit, then your chances of returning home, your chances of regaining independence, and your chances of surviving the stroke are very much improved compared with if you're looked after on a general medical ward. More recently, there's been evidence that if you're admitted directly from casualty onto a hyperacute stroke unit, then the mortality rate is reduced even further, the chances of having thrombolysis treatment is increased, and the outcomes are improved. So our aim is to try and get all suspected stroke patients onto a hyperacute stroke unit. So just to say a little bit about the national picture with regards to stroke. Stroke performance is monitored nationally in an audit called the Sentinel Stroke National Audit Programme, or SNAP. In 2008 in London, there were approximately 25 hospitals providing acute stroke care, but the SNAP data suggested that the care was varied and inconsistent across London, and a decision was taken to reduce the number of units providing hyperacute stroke care, such that now 8 hospitals provide hyperacute stroke care, with the remaining hospitals just providing the step-down care. As a result of this, the quality of care and performance in SNAP has improved remarkably, such that in the UK, 5 of the 6 top performing hospitals are now in London. It's acknowledged that London is perhaps the best place, not only in the UK or even the world, to have a stroke. People are now looking in detail at SNAP data across the country, and we know that across Yorkshire and Humber, the SNAP data reports varied and inconsistent performance across the region. As a result of this, there's been a recommendation that Yorkshire and Humber should have fewer HASU units. The suggestion has been perhaps having units in Leeds and Sheffield and Hull. We were keen to provide a HASU unit to cover the Bradford and Airedale area, and this is very much our aim, to try and improve care for stroke across the region. Nationally, there are difficulties in appointing stroke consultants. It's estimated that up to 50% of current stroke consultant posts are unfilled. Part of the reason for this is that stroke is a relatively new specialty, and there simply aren't the training numbers coming through to fill the posts. This has impact locally, because to provide an adequate HASU service requires a minimum of 6 consultants. Currently in Bradford we have 4 consultants, but in Airedale, as of August the 1st, the service will be running on 1 consultant who's working in a locum capacity. Previously there have been 3 stroke consultants working in Airedale, but since the resignation of 2 and long-term sickness of the 3rd, the service has been running with locum consultants only. Because of the recruitment difficulties which I've previously mentioned, Airedale has been unable to recruit stroke consultants to an adequate level and has been running on locum consultants for the past year or so. The difficulty with locum consultants is that they can resign at short notice, and this is what's happened currently. From August the 1st, Airedale will be run by 1 locum consultant. For the past year, out-of-hours cover for stroke has been provided by Bradford Teaching Hospitals Trust due to the lack of consultants in Airedale. The National Stroke HASU programme has come up with what a model HASU should look like in terms of activity and staffing. A HASU should have a minimum of 6 stroke consultants. It should take a minimum of 600 stroke admissions a year. There should be a daily consultant ward round including weekends, and there should be a rota of stroke specialist nurses to provide 24/7 cover for the ward and for accident and emergency, to cover thrombolysis. Currently, Bradford takes approximately 600 strokes per year. Airedale takes between 300 and 350 strokes a year. So a combined unit between Bradford and Airedale would provide sufficient numbers for the HASU model, which is described nationally, and would lead to better care and better outcomes for patients. We know that if patients are seen in a unit where strokes are seen frequently and thrombolysis rates are high, then the staff become familiar with the triage, the assessment, the management, and everyone's care level is lifted. So what will this mean for stroke patients in the Airedale, Wharfedale, Craven area? All patients with a fast positive suspected stroke will be taken to their nearest hospital providing a HASU service. For the majority of patients, around 85%, this will mean coming to Bradford. For patients who live closer to Leeds or Harrogate or Blackburn, they will be transferred to those hospitals which provide a HASU service. Patients arriving in Bradford will be scanned within an hour if they are suitable for thrombolysis treatment. All other patients will receive a CT head scan within 12 hours. There will be a repatriation policy such that patients from the Airedale area will be repatriated to Airedale Hospital, usually within 48 to 72 hours of their stroke, if it's safe for them to do so. We know that about 1 in 3 suspected strokes turn out not to be, and these are what we call stroke mimics. Patients arriving in Bradford with suspected stroke who turn out not to be will either be discharged directly home, which could be around 50% of such patients. The remaining patients will be admitted directly to Airedale Hospital for ongoing care. It's important to reassure people that Airedale will continue to have an acute stroke unit and stroke rehabilitation unit. There will still be a need for specialist stroke nurses, therapists and stroke consultants on the Airedale site. This is just about moving the HASU service to Bradford, and it will lead to better outcomes and better survival rates for stroke patients. The model is similar to the one for cardiology, where patients with suspected heart attacks are transferred to Leeds for urgent care and repatriated back within a day or two. There's no reason to believe this won't lead to similar outcomes and benefits for stroke patients. Thank you.